Hello, everyone. Good morning, good afternoon, and good evening. Thank you for attending this today's live symposium, How OCT-guided eye surgery can help you to focus on perfection, by Dr. Barbara Parolini. My name is Oscar Portilla from Leica Microsystems. Before we start, I would like to cover a few housekeeping topics. Please switch off your camera. If you have a VPN connection, switch off to avoid delays on the communication. In your screen, you see some application engagement tools located at the bottom of your screen. You can resize or move the screens to get the most of your desktop space. The slide area, as you see, you can expand and even maximize it to full screen view by clicking on the arrows in the top right corner. I'm sure you will have questions. Please, therefore, submit them through the Q&A engagement tool. And of course, Dr. Parolini and myself, we will try to answer all your questions during the Q&A session at the end. We have reserved 15 minutes for that, and we will, for sure, try to answer all your questions. If you need some additional information, you find this, please, in the resource list. Let me please talk a lot about Dr. Parolini. Dr. Parolini, Barbara Parolini, is a vitreoretinal surgeon. She comes from Italy. As you see there, she has performed more than 8,000 cases in vitreoretinal surgery. Especially, she has particular experience in macular buckling, in high myopia, trauma, and complex cases. She does as well anterior segment surgeries, as you see there, more than 5,000 cases, and more than 800 cases in refractive surgery. Of course, she collaborates with many companies, for example, here with Canon for wide-field OCT. She cooperates as well with Zeiss for wide-field imaging, Bausch & Lomb, and Alcon for surgical procedures, and of course, with Leica Microsystems. She has many publications, more than 25 publications in international. And she is a regular speaker and moderator for different international conferences, and she has numerous awards. As you see there, she is a member of many societies. At the moment, she is actual vice president of the European Vitreoretinal Society, and she reviews as well many publications and books. For more information, please visit the speaker bio tab. You want to get more information from Dr. Parolini. Dr. Parolini, good evening. Thank you for having you with us. Now, please, you can take over, and we will enjoy your presentation. Thank you for that.
Thank you. And thank you all on behalf of Leica and myself. I want to welcome you to this symposium. After 4 years of daily use of the intraoperative OCT, I'm happy to share with you my experience. And I will show you what I have collected, all the information that I have collected in these years. And in particular, when OCT guided me and I have followed. So these are the topics that we will touch. At the end of each topic, I propose a poll, and your individual answer will not be shown and will not be seen by the audience, but it is just to verify if I sent a message and just to see if I get it right. So let's start. Just sit back, relax, and enjoy the show. And so we start with the peeling membranes and see how OCT can be of guidance in peeling membranes. The common question is why peeling needs OCT at all? Well, the retina is transparent, the membranes are transparent, so how to distinguish one from the other? We can easily distinguish the choroid from the retina because the choroid is colored and the retina is transparent, but membranes are different. So here you see an epiretinal membrane and peeling, and I am finding the plane of separation between membrane and retina, but it is not always as straightforward as in this video. So one solution is certainly staining, but staining does not solve all the problems. How to see where there is no contrast? How to verify the position of an internal limiting membrane flap under air? How to verify the reaction of the retina in difficult cases of peeling with high risk of iatrogenic lesions. This is a good example. You see on the left the microscope view in a case of in an eye that had atrophic changes. So you see the contrast is no good at all. There are areas of atrophy, microhemorrhages. The patient has a mild macular degeneration, and instead on the right view, the EnFocus view confirms the position of the hole and the ILM flap with much more certainty. But a surgeon knows that under air it is always difficult to see, much more difficult than under fluid. This is a case of macular hole. I am at the end of the fluid air exchange. It is very difficult where the hole is and where the ILM is. Instead, it is only the OCT, as you can see in this picture, that shows exactly the hole and that the ILM flap is inside the hole. So surgery is finally finished. And in the next view, you see another example with, and it might seem similar to the previous easy peeling that I have shown. I grab the membrane and I move the membrane and I separate it from the retina. But if the previous peeling was inside the fundus on your left, the second peel was in the fundus of your right. And you can immediately see that this is a much more difficult case. This is a 50-year-old man. You can see it much better in this wide field picture. And it is very difficult to interpret. You can see huge areas of atrophy. This patient can see only through that central island of good choroid remaining. He had already a retinal detachment. I have fixed the detachment with good gain in vision, but then in a few years he developed a new problem. We can see here that in that central island of choroid, he developed a very thick gliosis, unfortunately, with the intraretinal macular fold and significant decrease in vision, and this is his only functional eye. So I think for a long time I decided to go and peel, but as you can imagine, I was extremely lakes. So this is the view through the intraoperative OCT and microscope during the peeling. So the questions in my mind were touching the retina again by pulling the membrane. Am I creating a hole? Am I peeling too much? And or am I peeling at all in moments of fear? And it felt extremely good to have always the confirmation of what I was doing. So you see, at first I was hesitating and just touching the retina, but then I could find the plane and peel the membrane. So on the left, the microscope view, it is a very important concept. On the you don't see the movement you don't see the movement of your instrument and of your hands. It is only the OCT that shows the effect of the movement and not the movement itself. If you want to see what you do, the whole movement, of course, you have to look through the microscope. OCT, you see the effect of the movement. Important because you know what you have done. Like here you see on the OCT view, you see the shadows, but also the edge of the membrane peel. You see the retinal folds that are starting to unfold. You can see if you made whole or not. So you have the constant confirmation of what you have done. This is the preoperative view on top, the postoperative view on the bottom. Unfortunately, this case was done correctly. And this is just another example of an eye with, after retinal detachment, you see the imprint of the encircling buckle. He had a good reattachment of the retina, but then developed an epiretinal membrane afterwards. And so I was obviously afraid to make mistakes during this peeling, because if you make a hole in an eye like this, basically the game is over. So having the confirmation is always a great advantage. And even here you see on top the pre-op and on the bottom the post-op results. So with peeling, I close the first session, and I would like to launch the first poll for you. I encourage you to select one of the answer to this question. Focus intraoperative OCT is very useful when peeling membranes. So A, when there is no contrast for the presence of choroidal atrophy. B, when there are light reflexes working under air tamponade. C, when we are afraid of inducing iatrogenic lesions with peeling. D, all the above. E, none of the above. So I hope if you followed, you will be encouraged to select one question, and in a few seconds I will see and show you the results. I will give you some time, don't be afraid, because nobody will see. It's just to have fun together, basically. Oscar, do you think I should show the results of the first poll?
Yes, wait a second.
We are so many already. Let's wait a few seconds.
Do it.
Yes.
Okay, go ahead, please.
Okay. Let's see, at least somebody answered. Okay. When there is choroidal atrophy, so all the above. Yeah, thank you so much. Thank you. I think that even if a few of you listened, you got the message correctly. Thank you so much. So let's move to the next chapter. How EnFocus intraoperative OCT can be of help in high myopia surgery. Okay, so recently I have published a new staging system of myopic traction maculopathy. So inside high myopia chapter, let's focus on myopic traction maculopathy. The staging system can be summarized in this one single table that shows the 12 stages of MTM, the evolution from one stage to the next, and the time taken to switch from one stage to the next. The table also offers guidelines, or at least proposal on my behalf, on treatment customized for each stage. So in some stages, it is advised just to observe and do nothing. In other stages, it is advisable to do vitrectomy. And in other cases, it is advisable to do macular buckle. And this is to ensure the best result with the least amount of number of surgeries. So I have seen that OCT is useful both in vitrectomy and in macular buckle. And let's see how. Well, in vitrectomy, it is extremely useful because very often in these cases, it is difficult to see the details. In this particular clip, you see that it is almost impossible in the microscope view on the left. It is almost impossible to see where the hole is, and very, very difficult to see the ILM. But on the right, the intraoperative OCT tells you exactly where the hole and the ILM are, and you can finish the case much more safely and with the certainty that you have done something. Look, this is the initial EnFocus view in a case that was particularly challenging. It was a 44 years old plastic surgeon colleague of mine, 27 diopters of myopia, with a very small, very bothering hole after taking care of his retinal detachment. So in the next video, you will see how the intraoperative OCT was useful in showing that I am stuffing the hole with ILM. And if you look on the left in the microscope view, it was very difficult because the hole was extremely small. And here I already had stain twice. But the staining, as you well know, in high myopia is not always so useful because it washes out, and then after a while you just can't see. But on the right, look at the OCT, and you know exactly that you have stuffed the hole with the ILM, and this is what I wanted to do. And this is the final EnFocus view that basically confirmed that I was done with the case. But even with macular buckle, the OCT is extremely useful. So here you will see the insertion of the buckle. It is a silicone sponge with a titanium stent bent like an L. You see the insertion in the superotemporal quadrant. And in this kind of surgery, as you can imagine, the main goal is to put the buckle exactly in the right spot. You have to have to look through the panoramic viewing system. You can use transillumination, is very useful. But if you have the OCT, you know the location of the buckle, which has to be under the fovea, of course, but also the amount of indentation. You can ask the OCT how much you are pushing the buckle exactly in the right spot. And so it is one extra information that you can have, of course, only from the intraoperative OCT. In another case, like here, a combined surgery, buccal and vitrectomy, I could see that the macular hole highlighted by the white arrow was not centered exactly on the buccal. So I could adjust the buccal and place the buccal exactly under the hole, as you can see in the bottom picture. And even more, again, under air. You know that in high myopia, you see nothing, and under air, you see even less. So in the microscope view on the left, you see there is no contrast, so you have no idea where exactly the macular hole is. You have options. You can stain again, but if you have to aspirate the staining with the risk of aspirating the inner limiting membrane flap as well. And instead, you look on the right through the OCT. So you see, pointed by the arrow, you see the hole, the ILM flap on top, exactly on the macular buccal. No need to do other maneuvers, which are just risky. So in the next video, it was a nice memory. I performed surgery in a similar case, a macular detachment with macular hole at the Floretina 2019. And it was, again, a vitrectomy combined with the buccal. So you will see the intraoperative OCT showing the end of surgery with the hole almost closed and the buccal right under it. And this was the pre-op of that specific case on top, with the huge scotoma on microperimetry vision 0.1. And on the bottom, you see the 1 month status with the disappearance of the scotoma and the retina attached with the hole closed and a flat retina on top of the macular buccal. In this particular picture, I am showing you that in a few cases, I have tried to implant the buccal without the microscope and without looking directly through the microscope and without endo-illumination, only with the guide of intraoperative OCT. It is, of course, it is more challenging, but it can be done because I have the microscope and the panoramic viewing system pointed on the cornea, of course. The OCT is looking through the biome, and on the video on the monitor, you see my coworker pointing at the correct position of the buccal, and the surgery was done. So actually, in this picture, you can appreciate how useful it is to have an external monitor so you can share the view with everybody. And in this specific case, it was my view, it was the surgeon view as well. So, done with high myopia chapter. Let's run another poll. Don't be shy. The question is, EnFocus intraoperative OCT is then again useful in high myopia, but why? A, because OCT measured the size of the hole and the depth of detachment, or B, because the EnFocus show what the microscope cannot show, is the ILM of the hole, the indentation of the buccal, or C, because the eye is very long, so we need an intraoperative OCT. Okay, let's wait a few minutes and see question you choose based on what I've just told you. Oscar, you count the time, right?
Yes, I'm doing. Unfortunately, we have a little bit delay on the communication. When you change from a slide to a slide, wait a little bit, please, okay? To change the slide, because we have some delay in the communication, please. But everything is fine. Thank you. Okay, let's see the answers. Especially when the videos.
Okay, I will do. So thank you. We highlighted the message that the EnFocus is useful in these occasions. Thank you. Let's switch subject. And I would like to show you now how the EnFocus is useful in subretinal surgery. As most of you know, I perform particularly choroidal transplant, but the concept that I will show you can apply to any kind of subretinal surgery. These are the publications that I made after 15 years. Actually, it's now 15 years and not 10 years of experience with this of autologous transplant of choroid. This is something like high myopia that basically took all my attention, and these are the topics that I have studied the most in my career. Let's start in summarizing the main steps of surgery. So to perform this type of surgery, you have to make a very wide vitrectomy, and then you have to detach the temporal retina with a small gauge needle. And then you have to cut a huge peripheral retinotomy at the ora serrata. Then, if there is a CNV, you have to remove the CNV. And then you have to isolate a full thickness patch of RPE. And then you have to transplant the thickness, the full thickness patch of RPE and choroid under the fovea. And finally, you have to reattach the retina and select a final tamponade that most of the time is silicone oil. So this is just one example to show you what this surgery can do. On top is the preoperative view of a patient with 0.2 vision, no reading ability, and a huge CNV under a very good looking retina. You can see the external retina is still intact. Underneath, you see the OCT at the years follow-up, 7 years post-operatively. Vision is still 0.6, and she has reading ability. So let's see now how the EnFocus OCT is useful in subretinal surgery. This is just a nice view of a calcified CNV that I am touching after elevating the retina. And this is the view of the RPE choroid patch after I transplanted the patch right under the fovea, but here you see the view without the retina on top, just to confirm the correct position of the choroidal transplant with no wrinkles. But this is more important. This is when the role of intraoperative OCT comes in place, because it is very important to know that you did not make any macular holes, and there are no residual PFCL bubbles underneath, because it is mandatory to use PFCL in the previous step when you detach the retina, when you move the RPE, every step is performed under PFCL. And finally, you exchange PFCL with the final tamponade. So at this particular point, it is extremely important to know there is no PFCL left under the fovea. And I show you that we have to detach the retina by injecting BSS under the retina. That step is at high risk of inducing a macular hole. This is true not only for choroidal autologous transplant, it is true for any type of subretinal surgery. And with the OCT, you can see small holes made by this maneuver. And if you know that you made them, you can do something about them. So, about subretinal surgery, the last poll. This is the question, and EnFocus intraoperative OCT is very useful in subretinal surgery. Let's see why. A, because the EnFocus can show the presence of macular holes and subfoveal PFCL bubbles. B, because OCT measures the size of the CNV. Or C, because it increases the magnification 4 times. Okay, let's run the poll. Oscar, was the delay taken care of this way? Or should I wait more?
Yeah, it's fine. It's much better. It's much better. And we are good on time.
Okay.
Half an hour. It's fine. It's fine.
Okay.
Okay. Go ahead.
I still have nice things to tell you. Okay, let's show the answers. Thank you so much. Thank you. I was not so bad in selecting the questions afterward. Okay, so now let's move to even more interesting subjects in our daily practice. So how is intraoperative OCT useful in retinal detachment surgery? I think these points are the main areas where the OCT is useful. First of all, to see the behavior of the retina, again, under PFCL or under air and under silicone. Second, to exclude the presence of PFCL bubbles under the retina. Third, to decide whether to kill or not to kill the ILM. And fourth, to differentiate areas of schisis and detachment. Okay, let's see in the next video, just to show you when the injection of PFCL squeeze out the subretinal fluid, and in this particular case also subretinal blood that had formed in the previous maneuvers. And we know that when we switch from fluid to air, in the fluid air exchange, it might happen that the macula redetaches because you have aspirated the subretinal fluid, but some remains stuck under the macula, and the OCT confirms that. Although the main point of surgery is basically just to attach the retina and attach the brake. But again, in this particular video, I want to show you again the video, because in here, sorry, I had a delay, so I'm not sure you have seen the video. I am injecting, switching from air to heavy silicone oil, and where the retina was elevated, now it is attached under the action of silicone oil. So basically my point is that through the intraoperative OCT, you can study the behavior of the retina under different tamponades. And that might be useful in many cases to decide whether you have to do more maneuvers or if you are done with surgery. So my point is that we should also use the OCT to increase our attention and ability of observation. Look at, in this case, for example, this was a retinal detachment, and in this phase I just reattached the retina under PFCL. Observing the retina is attached, but not only. We see the small bleb-like detachments of the retina, and we know that in some cases the small detachment do not reabsorb even after surgery for a long time. I am wondering, looking at this image, appreciate only during surgery, of course, because this is OCT with the PFCL tamponade. That maybe those bleb-like detachments are due to microfolds of that might remain and start in surgery and remain even afterwards. So again, here my point is that through the intraoperative OCT view, we can understand the behavior of the tissue and understand the reaction to any maneuver that we do and the meaning of them, so we can react to and do something about any observation that we do. So another important point is, let me go through the, okay, another important point that I mentioned even in subretinal surgery is that we can see if there are remaining bubbles of PFC under the retina, and you know that when we create some turbulence during the exchanges like I'm doing here, it might happen to have some PFCL going through the brakes, and so it is extremely important to know immediately during surgery that that happened, and so we can do something about it. Third point is that we have to decide in retinal detachment surgery whether to peel the ILM or not. And both peeling or not peeling have pros and cons, because if we peel the ILM, it is described that we decrease the chance of having secondary epiretinal membranes. But again, peeling is a maneuver at risk of inducing iatrogenic macular holes. So I have seen that the OCT might help deciding when to peel and not to peel. Look at this example. In this example, this was my first observation. I had attached the retina. I was ready to peel the ILM, but then I looked at the fovea. Look at how thin is the fovea. So I immediately decided not to peel, and I changed my surgical decision because I was then afraid of macular hole. So I decided not to peel in that case. In this case, things are different. Look at the video, because the fovea looks much thicker and there are retinal wrinkles. So I thought it was not only safe, but advisable to peeling. And in fact, as you see in the video, I do not induce any hole, and it looked safe to perform this maneuver. But again, as I said before, pay attention to what you see and pay attention to what the OCT tells. Like here, I had decided to perform the ILM peeling because I was looking at wrinkles in the retina. Now I have peeled the ILM. I would like to show the video again, if possible. Yes, like this. Because you can see that even at the end of the peeling, there are still wrinkles. I did not remove all the wrinkles just peeling the ILM. So what should I do? Are there more membranes to remove? Why are there more wrinkles after peeling? If you look on the OCT scan, you see that there are microfolds in the external retina and also microfolds in the choroid. And those were the cause of the final wrinkles. So there was no point of going to do any more peeling. And that helped in the interpretation of the case. This is a difficult case of retinal detachment, but associated to congenital X-linked retinoschisis. And in the first surgery, I have done vitrectomy, of course, extensive vitrectomy with the removal of the inner retinal layer above the schisis, encircling buccal, and siliconoid. In cases like this, you know from the beginning that you will have to operate more than once. And what I'm showing you here is the intraoperative view of the second surgery. So you see that the amount of intraretinal traction is much less compared to here, but still there is a subtle retinal detachment in the temporal area, and there are many uncertain findings. In particular, I highlighted A, B, and C. So in A, is there a hole or a cyst? In B, are there retinal folds, PVR, or subretinal strands? And in C, look at that. Are those two bubbles of PFCL, subretinal PFCL, maybe left from the previous surgery? So the EnFocus was very, very helpful, because how much time I should have spent just looking through the microscope. But with the OCT, I had an immediate answer. So I knew that in A, there was actually a small hole and also a cyst close by, but I had to treat the hole, of course. And B were areas of schisis and fragments of the inner retinal layer that I had trimmed in the previous surgery. So no subretinal bands, no PVR, just schisis with residual traction. And C, they were not subretinal PFCL bubbles. They were just retained areas of schisis, intraretinal schisis. So let's close the retinal detachment chapter with another poll. And the question now is, if EnFocus intraoperative OCT is useful in retinal detachment, let's see why. A, because it removes the light reflexes, or B, because it offers information on the behavior of the retina with the tamponades. C, because it tells if there are PFCL bubbles under the retina. D, because it might differentiate areas of schisis from detachment. E, all of the above. F, all of the above minus A. Okay, Oscar.
It's good. Let's wait a couple of seconds.
Yes.
Wait, yeah.
Are we on time?
40 40 minutes. We need a little bit.
Okay.
Please, a little bit. Very nice. Thank you very much, Dr. Parolini. It's really great. A little bit faster. We are at 40 minutes now, and we have still 20 slides, more or less. Okay,
yeah,
go
I
ahead.
had slowed down for the delay, but I will take care. I will adjust.
Very nice.
Let's see the answers. Yeah, thank you. All right. Actually, yes, it doesn't remove the light reflexes, but we can see better through the light reflexes. So even here answer is not so wrong. Okay, let's change subject. So from detachment to difficult PVR. So in PVR, the OCT is useful for all these reasons, but 1 to 4 I already highlighted in retinal detachment, which, and of course they are common, but 5 and 6 are peculiar to PVR. How to locate immature intraretinal PVR and how to judge residual traction. So this is a difficult case of PVR, but to me, this is easier than the following. This one. I think this is worse. Why? This patient came for a second opinion, and he already had 5 surgeries for retinal detachment. And at first view, it seems okay, but running the OCT, preoperative OCT, you see, unfortunately, there is a subtle detachment relapse in the inferior quadrant. This is worse because this patient is expecting more and he's tired of having surgeries. We cannot make mistakes. So let's ask the OCT how to locate your PVR. Look at this picture. I think, pointed with the arrow, this is a pathognomonic sign of intraretinal immature PVR. And the OCT is extremely helpful because I can tell you, I compare with staining. You don't have the same answer from staining when the PVR is immature, because this kind of membranes sometimes don't get any staining. This is another spot. Again, you see the basically micro wrinkles inside the retina with a hyper reflective spot in the retina through the OCT. So if you see that sign, you know that you have to peel there. Unfortunately, I don't have the video here, but if you're interested, ask me. I will send you the video that I have no time to show here. The last point, how to judge residual traction. Well, you know that one of the greatest challenge in PVR surgery is how to judge residual traction. So the question is, can the OCT be a traction detector? That would be ideal. Look at this case. Looking at the microscope, you can, how many times you have found yourself in a case like this? Should we lift the retinotomy? Should more membranes be peeled? Is there a residual traction? It is very difficult to judge that through the microscope view. But through the OCT, you see that the edges of the retinotomy are minimally elevated and contracted. There are epiretinal membranes. Again, here, this is not a good sign because the retinotomy is contracted. This is at the very edge, and still there are epiretinal membranes. On top, the photo that I have just shown, on the bottom, after taking care of the epiretinal membrane. See, there's a huge difference between the top image and the bottom image that shows a relaxed edge of retinotomy. Even here, these edges look now more relaxed and there are no epiretinal membranes left. So I think the OCT can act as a traction detector. Again, another spot with a relaxed retina, no more traction, the case is done. This is the postoperative view of that peculiar case. So let's see now how the OCT help when there is no preoperative view due to media opacity, like a vitreous hemorrhage. In these cases, we cannot perform a preoperative OCT, so we start the case like that. we don't know what we have to do on the macula. So having the intraoperative OCT, we know that, like in this case, there is a small lamellar hole, there is not so much traction. We can decide, at least we can decide intraoperative and not postoperatively what to do, so we don't have to take back the patient for another surgery. In a case like this, we maybe made that iatrogenic small hemorrhage during the peeling. The OCT shows that we don't have a hole, a iatrogenic hole, so no need to do any more maneuvers, and we can just go ahead with surgery. And in this case, it started with the vitreous hemorrhage. And when I removed, I found those huge intraretinal hemorrhages that were not present when I had checked the patient 1 month before the vitreous hemorrhage. These were a surprise. So I saw with the intraoperative OCT that there was just blood inside the retina. The macula did not need any peeling. And those were very likely hemorrhage that occurred at the moment when I started surgery for like an ocular decompression retinopathy, because this patient started with a high intraocular pressure. And when I initiated surgery, I decreased the pressure very abruptly, and he developed the hemorrhages intraoperatively. But at least with the OCT, I knew that I just had to wait and no other maneuvers had to be done. The OCT is extremely important for training and education. You saw this image before with an external monitor everybody can see. And during training, the fellow can have a feeling of each maneuver he does. He can see when he's not touching the retina and when he's doing something. You see here that the retina has some resistance, and you see when the peeling is actually efficient and the retina starts to open up. So very, very good for educational purposes. So in summary, I would like to conclude that I found these main advantages from the intraoperative OCT. First of all, the confirmation of what we see with the microscope when we wonder, and the ability to see what we don't see with the microscope, which is even more important. So we gain precision, we gain speed, we gain knowledge, we can use it for research purposes and for education. And to me, this is at least one step closer to perfection, which we never reach, because perfection is always in the next case. But certainly to be able to see is to be able to do. So I would like to take the opportunity to thank you and to thank Leica for the cooperation and for this symposium. Oscar, the word to you.
Thank you. Thank you very much, Dr. Parolini. I'm sure the participants, they enjoy it. I am sure. We have a couple of questions. We have still 10 minutes. Dr. Parolini, can we go through the questions, please?
Okay.
Do you hear me? Okay. The first question. I use endocaine green for staining. Can I use an OCT, intraoperative OCT?
So as I said, of course, in indocyanine green, it is one of the staining that we have available. It is a good one among others. Stainings are very, very useful, and we all use them. I use them all the time. I just have noticed that, as you might know, some cases can restain, and in other cases, staining is not so useful, especially when you stain, but underneath there is no contrast from the tissue. And those are the cases when the OCT is more helpful than staining. So I'm not saying we should avoid staining. No. even because OCT is still rare and not so easy to have. But I'm telling you that it might help where staining cannot help. Are there other questions?
Yes. As you told, the choroid graft is useful only when you have a good neurosensory retina?
Yes, exactly. We can only transplant the choroid. Unfortunately, we cannot transplant the retina. Actually, I have tried to transplant the retina too. I have published, but the results are not so good, as you can imagine. So the best results of autologous transplant of choroid are obtained when the external retina is still intact.
Okay. Do you use the OCT to choose your RPE graft to transplant?
No. No, I don't. Partially, that's the answer, because the main way of selection is to look directly, in this case, a good color of the RPE with no atrophy. And then when I select areas of no atrophy, the OCT, I check the thickness of the choroid. So if I can choose among spots with different thickness, I select the one with the thicker choroid. Go ahead,
okay.
Oscar.
Yes, you see real-life scan in your eyepiece of OCT when you peel, or you just see on the screen the OCT?
So with the EnFocus OCT, I use the monitor. So now I have the monitor very, very close to my eyepiece. And I basically look, I do my movement, and in some cases I just stop and check the monitor. This is why before I said your movement you can see only through the microscope, and you have to look through the microscope. But then you can stop and see the effect of your movement through the intraoperative OCT. Now this maneuver with the integrated version of the intraoperative OCT are more and more easier and easier in time. And less we need the technician, although I could not do without my technicians. And I want to thank Veronica Matello and Angela Lucente for the great help they always give me with surgery.
So you answer actually this question. Do you need someone who operates the OCT system during the surgery? But I believe you can also independently use from the foot pedal.
So I have been using the EnFocus OCT for 4 years. And let's say that at the beginning, I was totally dependent on a technician. And now I can do more and more in time independently, because the commands are on the foot pedal, which can be programmed as you want. And of course, with the help of the technician, everything is faster. So we will see with the integrated version of the EnFocus how things will change as far as independence of the surgeon as well.
Perfect. Another 2 questions, please, we hope we finish. Is it possible to measure length or width? It is intraoperative. Yes. And how accurate are the measurements? How accurate are these measurements?
It is possible. Well, they are accurate because I have tried to compare at least what I have done, the comparison between the preoperative OCT and the intraoperative OCT, and they are comparable. So that's why I'm saying they are accurate. You can do it intraoperatively. There is a caliper.
The calipers, yes. Another question, can we decrease the myopia with use of atropine?
This question is not clear, Oscar.
Yeah.
Can you read it again?
Can we decrease the myopia with use of atropine?
Okay. Well, this question is not related to what we were speaking about, but it's because you know that I deal with myopia all the time. And it is, we cannot say this is totally demonstrated, but there are strong studies that shows that if we use a dilution of atropine in infancy, we can slow down the progression of myopia. So we cannot decrease, we can slow down the progression, which is...
Okay. If we add 3D visualization to this amazing intraoperative OCT, will be
yes,
great?
I look forward to that. Yes, I like this question. I have used 3D and system, different types. And my dear colleagues, we know that when we shared brainstorming on this topic, that I found a 3D system extremely useful in macular surgery, maybe not yet so useful in the periphery or in the anterior segment, but I think that that's the way the future will go. In the end, the combination of 3D surgery with intraoperative OCT will be great. I can't wait to have both and to have the evolution of 3D with good details also in the peripheral retina compared to the central retina. Yeah. Thank you for this question.
Is that your surgical workflow interrupted when you are using the OCT?
This is a good question. Yes, I do interrupt my workflow because, as I said, I look my maneuver through the eyepiece. Now I don't have 3D, so I always use the microscope. And then when I want to watch the OCT, I stop. Even with my hands inside the eye, I stop and I look to the monitor on my right, very close to the eyepiece. But what I have observed in time is that at the very beginning, surgeries were much longer because of the OCT, because I wanted to check everything and it took time to learn and I was dependent totally to the technician and it took time. It was slowing down surgery. But now I feel the opposite. I think surgery is faster with the OCT because from the OCT, even if I have to stop the flow, I have immediate answers. I have immediate confirmation of what I have to do. So I don't spend time wondering what I have to do. I just know. So in the end,
the confidence.
Even if I want to stop, the confidence increases and I don't feel it is slowing down.
Now one question, I think it's an interesting question, Dr. Barbara. Can you now imagine performing your complex cases without the intraoperative OCT?
No. Of course, and again, I'm operating. No, come on. I'm operating in different ORs. So I don't always have the OCT with me. But telling the truth, the most difficult case is the challenging one, the one that I fear. I try always to switch to the OR where I have the OCT because if you will try, you will see by using it, your confidence is so enhanced because you know what you have done. So you are less dependent on the day after syndrome. We know that we surgeons always suffer from the day after syndrome, because we know only the day after what we have really done. And I think that the OCT partially takes care of the day after syndrome, because we answer immediately. So, yeah.
If we compare the image quality from the EnFocus with the OCT in your practice, are comparable?
No, I use the EnFocus.
The EnFocus, yes. But if you compare, saying here, the image quality of the scans,
sorry. Yeah, with
compared
other
to the
preoperative
OCT in your practice.
Yes. Now,
are comparable
yes.
with
4 years ago, it was not exactly. They are comparable. That's why I've been showing you some pre-op with intraoperative OCT. Please, if you are interested, write me an email. I can send you maybe for the same case, the pre-op and the intraop, so you can see that they are totally comparable. Sometimes during surgery, you are dependent on the clarity of the media, the alignment of your eye. So the quality of the lens, and maybe the lens gets foggy. Of course, you have to do anything in your power to have clear media. You've taken care of that. The images are comparable. The quality of the images are comparable.
Perfect. Last two questions. The doctor asking about the decrease of myopia, the question before, he's asking in which age we can use atropine for a slow demonstrate the myopia?
Well, I don't remember exactly in which range, but it has been done in elementary school, so you can start very, very early. And it makes sense, because you know that high myopia never stops. When we deal with a degenerative myopia, it never stops for life. And so I think it makes sense in elementary school, but it makes sense in teenage, and makes sense even in higher age for high myopia. So, because it never stops. But I think the studies have been done only in school age and not in adult. We can verify that.
The last question, and this question I think, Dr. Barbara, is more for Leica, for me. Can you see the ingenuity, or can you use the ingenuity with the EnFocus? And is the scan also shown in the ingenuity? Very short, yes, it is possible.
Okay.
Good. Mm-hmm. I think this was the last question. Thank you very much, Dr. Barbara, for this great symposium. A lot of participants from many, many countries. It's amazing. That's why I started saying good morning, good afternoon, and good evening, because we had participants from almost all continents. Great presentation, and thank you very much to everyone.
They were not just my relatives, Oscar. Maybe they were not just my relatives. Maybe two colleagues as well.
Yes.
Thank you.
Thank you very much. Congratulations. Thank you.
Email me if you have more questions. I will be happy to answer to all the unanswered questions. Thank you all.
Perfect. Thank you. Thank you very much to everyone. Bye-bye. Bye, Dr. Parolini. Thank you very much.
Bye. Thank you.
Bye. Bye-bye. Thank you.